Perfect. So, quite a few followers, as you said, no pressure. I've also seen in the chat one of my first mentors from about 12 years ago. So even more pressure. Good evening, Clive. Hopefully I'll do you proud. But yeah, so I've been asked to come and talk to you about ECGs in transient loss of consciousness tonight. And so shortly we'll whiz over that. But as I've been introduced, I'm Silas. I'm a critical care paramedic currently working for an KSS Air Ambulance Trust. I've got a special interest in ECG interpretation. I've been teaching it for a few years now. I'm also the creator of the ECG, the pre-med ECG interpretation ECGs, clinical assessment and stuff is obviously really helpful. So that and slow AF is worth consideration as well. So clearly a pathophysiological bradycardia, the reason it can cause syncope is because ultimately if it will put a cap on the amount of cardiac output the heart's able to produce. So it might be that you turn up to patients who are really compromised, even sitting still, look really sweaty and pale. It might be that patients just feel a little bit breathless, but otherwise okay. But actually, when they stand up and exert themselves, they have an exertional syncope. And that's just due to a limited cardiac output because the heart rate isn't increasing to match the exercise. The other thing that's worth considering is slow AF, because this can lead to a couple of causes of syncope. So slow AF generally only occurs if in two contexts really. One is if the patient's medicated, and someone's already mentioned beta blockers. Classically AF patients would be beta blocked, and it might be that if they've taken too many by mistake, or their prescription is too high, is too excessive, or things like renal problems. So they've got reduced, if they've got like kidney problems and they're not excreting the drug as quickly as they normally would, and that can lead to a kind of build up of that level of drug in the system. And again, that can cause too significant an effect on their heart rate. And the other reason for a slow AF is an AV node problem. So normal AF, in speech quotations, I suppose, is a ventricular rate of around 110 to 160. And the way that happens is that atrial fibrillation is basically the atria have a lot of different cells firing, all not in communication with each other. And all of those electrical impulses get thrown at the AV node, which is quite a kind of clever system in itself, the AV node. So it limits the amount of those impulses that are passed through to the ventricles. And by limiting the amount of impulses that go through to the ventricles, it means that the ventricular rate stays low enough for refilling and therefore to maintain cardiac output. Because the normal atrial rate in AF from the atria into the ventricles, outside of the normal pathway of the the AV node bundle of His system. And so that leads to a couple of changes. The main kind of thing to be aware of is a short PR interval. And so if you imagine, as most people will know, and if you don't, this is the case, the way the AV node works is electricity flows through the atria, it gets collected in the AV node, and then there's a brief pause, which is the PR interval you see on an ECG. And that's a kind of flat line of no electrical activity or no visible electrical activity as the electrical impulse travels through the AV node, down the bundle of His and through the bundle branches. And then you start to see the QRS complex when that electricity is released into the myocardium. So what that results in is a sort of delay between atrial contraction and ventricular contraction, and that usefully allows blood to fall from the atria into the ventricles before it's squeezed back out. So what happens with accessory pathways is they have this bridge of tissue which doesn't have any of that ability to slow down or control where the electricity goes. So they get an immediate delivery of that electrical impulse into the ventricles. And because it's immediate and not going through that conduction system of the AV node, you don't get a PR interval. You get a really short one because the electricity is flowing straight in. So a short PR interval is the kind of first finding to suggest an accessory pathway. This is often followed by what's called a delta wave. So you can see in here lead 1, lead 3, most of the leads actually, AVL, V2. Probably the best example of it is in V4 in this ECG. You can see that the QRS complex is broad, but it's broad in kind of a specific way, where the initial upstroke of the R wave is at a more shallow angle, and then it straightens up and it basically ends in a normal QRS complex. And that shallow angle is because the electricity, instead of going through the conduction system, is going straight over that little bridge of tissue, being released straight into the ventricles. Because it's outside the conduction system, it passes through the myocardial tissue slower, and so you get a shallower upstroke until it meets the top when it hits the electricity that has been going through the conduction system and ends in. And it causes abnormal movement of, in fact, there's different theories around it, but the dominant theory is that it causes abnormal movement of electricity through the ventricular myocardium. And similar to the outflow tract issues we've discussed, that abnormal movement through the myocardium can predispose to ventricular arrhythmias and trigger ventricular tachycardias. And then finally, the one to consider is early depolarization, which people have probably heard of as referred to benign early repolarization. And we'll discuss that in a second. But essentially, early repolarization is characterized, and this is an example of it you see on the screen here. It's characterized by an early upstroke of the ST segment. So the ventricles are repolarizing early. And so you don't get that flat ST segment that you would get in normal physiology or with a normal ECG. It's called early, so it should, again, the title's wrong, it should be early repolarization. So it's called early repolarization as opposed to an MI because it's happening in the context of normal physiology. It's just a normal finding for some people, and it's more common in younger patients. But as I kind of mentioned, you can get similar patterns with MI, and so you have to be careful you kind of have to be careful in making that diagnosis. And ultimately, it really early repolarization is a diagnosis of exclusion. So you really need to rule out MI with blood tests and stuff to be absolutely sure. And so, as I say, people often refer to it as benign early repolarization, but it literally cannot be called that because it's associated with increased mortality or has been linked with sudden cardiac death, which I'm sure people will agree is not a benign thing to be linked with.